Everybody, thank you for being here and taking the time out of your busy schedule to be with the Georgia Critical Access Hospital Community of Practice, the 2013 Yearly Summit. I first want to thank the State Office of Rural Health and Dawn Waldrop for inviting us to continue the good work that we do. Quick introductions of our team. Charles Owens is the Director of the Center for Public Health Practice and Research, and Angie Peden is the Associate Director for the Center. There's all of our pictures popping up. Dr. Appinting, Dr. Apuku, and Dr. Kimsey and myself were all on the call today. And we'll be running through a quick agenda. And ultimately, I just want to thank you all for providing us the opportunity to serve you. I know the State Office of Rural Health is passionate about our state hospital, our critical access hospital statewide, and all the amazing work that you do. And what we've traditionally done is in the summit, we give you a quick summary of some of the programs and activities that we've done in the past and what we envision serving you in the future. So without further delay, I'll ask Dawn. Dawn, if you want to say something, otherwise I'll turn it back over to Angie, and welcome everyone. Thanks for being here.
Bill and team, I just want to say hello and welcome everyone, and I'm excited to kick off this next year with Flex. I look forward to all the work we're going to do, and I know our hospitals are going to be excited to participate as well. We'll have great participation. I just know it's coming. So thank you so much, and I'll turn it back over to you. Thanks.
Okay, thanks, Dawn. So to get us started, we started this initiative last year. We are giving out a few awards, and these are performance related improvement in management and engagement awards. We're calling them the Prime Awards, and we are really excited to give a few of these out this year. So I'm just going to go through those quickly. And then after I announce all the winners, then I'll give a few minutes. If there are any hospital representatives that would like to say a few words, we'll open it up to you. Okay, so our first winner is Elbert Memorial Hospital, and they are being recognized for their commitment to workforce development and organizational learning. So congratulations. Next, we have Candler County Hospital, recognized for commitment to workforce development and organizational learning and evidence-driven strategic planning. So congratulations, Candler. Also, Liberty Regional Medical Center. They are being recognized today for data-driven continuous financial operational improvement and commitment to workforce development and organizational learning. So great job, Liberty. And also Optum Screven. They are being recognized for their commitment to workforce development and organizational learning. Jeff Davis Memorial Hospital, recognized for commitment to workforce development and organizational learning. And Clinch Memorial Hospital, also recognized for commitment to workforce development and organizational learning. Okay, so before we get started with our guest speaker, I would like just to give just a quick moment for any hospital representatives who've won an award. If you'd like to say a few words about the program and how it has benefited your hospital, that would be great.
Hey, Angie, this is Michael Purvis. How are you doing today?
Great. Thanks, Michael.
Hey, I just want to give a shout out to Georgia Southern. You know, when I started at Candler County Hospital back in December of 19, one of the first collaborative relationships that we started together was strategic planning. And we've been fortunate and blessed enough to have a doctoral student join us now from Georgia Southern. And she was part of that first strategic planning session. And she was in the hospital late last week, and we gave her a tour, and she just couldn't believe all the operational and facility improvements that we've made. And so, you know, you guys help us with our community perception scores that we got for the first time last year. And you also are helping us on our journey with employee engagement, making sure that we have a good plan around some findings on surveys, and we've been able to move the needle with employee engagement as well together. So, you know, I can't give you enough credit of your team's access and the level of students that you're sending to Candler County Hospital that we're able to precept. And we've actually hired a couple this year as well.
Wonderful.
So I just want to thank y'all, and our success is your success, and I appreciate all the help and support.
Wonderful. Thank you so much, Michael. Anyone else want to say a few words?
This is Derek from Liberty. I would just like to say that we invest a lot in our leadership, but I know we put out the LEAD Academy to all of our leaders and supervisors, and we had great success with that. A lot of positive feedback from the ones that did participate. And you can tell it made an impact across the organization. So we appreciate that, and we appreciate the recognition of the award.
Wonderful. Thank you so much. We're going to talk more about the LEAD Academy in just a little bit. Anyone else? All right. Well, we are going to go ahead and get started with our first guest speaker. Charles, would you like to introduce Donna?
Absolutely. Thank you, Angie. I am extremely pleased to get to introduce Donna Cohen. Many of you know Donna. She's like me. She's been around for a while and worked with us on lots of programs and projects as we have worked with a variety of hospitals over the years. Donna, as you know, she serves as Director of Quality Programs at Alliant Health Solutions. She, of course, leads the hospital quality improvement work for Alliant. Of course, we also recognize her and celebrate her as she is a registered nurse and a certified case manager, and has over 30 years experience in the field. So Donna, welcome. Thank you for being here today and sharing with us.
Thank you, Charles, and congratulations to all of the award winners, and thank you to Georgia Southern and the Office of Rural Health for the opportunity to spend a little bit of time with you today. I know your time is precious, so I'm going to try to make this very valuable for you. Let me just do a check, make sure y'all can see my screen.
Yes.
Perfect. All right. So we don't need to go there. So on a personal note, I have to show you my babies. So I'm a grandmother now of 2 children. And so we have Cohen and Ellie, and hope all of you Georgia fans love the fact that these little kiddos are huge Georgia fans. So this is my pride and joy, and what I spend most of my weekends doing when I'm trying to download from the stress of the Monday through Friday work, which I know y'all all can relate to. So as Charles said, I am the Director of Quality Programs for Alliant Health Solutions. We are a quality improvement organization, and many people probably do not know what a quality improvement organization is. Currently, there's 13 quality improvement organizations across the country, and the quality improvement organizations were founded in 1902 under the Social Security Act. And the purpose of the Quality Improvement Organization is to assist healthcare facilities, whether that's hospitals, nursing homes, physician practices, in improving quality of care, specifically to beneficiaries. So this statutory authority was given to help protect our Medicare dollars. And I'm not going to go into all of the provisions and all that. If you want that information, you can see what the act specifically is. But it's been around since 1982, and the key factor is that it's funded by CMS under the Social Security Act. So currently we are on the 12th scope of work since 1982, which was the first scope of work. And these scopes of work have lasted from 4 to 5 years. Currently we're on the 12th scope of work, which is a 4-year contract with CMS, and that will end in September of 2024. So we envision getting an additional scope of work, which will be the 13th scope of work, around summertime with the anticipated start date of September of 2024. So I wanted to take this opportunity to share with you the vision that CMS has for the 13th scope of work. It's going to be structured significantly different from our current work that we're doing now. The program will focus and be designed with the Health and Human Services Strategic Plan, the National Quality Strategy, the CMS strategic pillars, as well as behavioral health strategies and health equity strategies. I know you are all very familiar with the health equity strategies. If you are an HQIC hospital participating with us, we've done a couple of learning events on health equity and the strategy that CMS is putting together as far as health equity is concerned. CMS certainly wants to target quality improvement models where the evidence suggests that they will improve outcomes. Now, traditionally, I can remember, as Charles said, I've been around for a while, and I can remember in the 11th and 12th scope of work, CMS message to us was, we're going to be very specific on what we want you to do, but we are not going to be specific on how you do that work, how you achieve the outcomes that we want you to achieve. So with the 13th scope of work, CMS is telling us that they're going to be very specific on the what and the how, and with clearly defined interventions. So when I speak of interventions, I'm talking about what processes or what tools do you use in your healthcare facility to make sure that your outcomes are improving. Also, CMS wants to shift the program from us just sharing written materials. When I say us, the QIO programs, sharing best practices, tools, and resources to really work with healthcare facilities on quality improvement implementation. I feel like we're already doing that. We certainly talk about root cause analysis. We do some boot camps on PDSA. That's the process improvement model that we use. So we are already doing that, but CMS is really saying that they want us to focus more on the quality improvement implementation and want the QIOs to be recognized as the national leaders in quality improvement across the country. It is important, and we're already seeing this in the 12th scope of work, it is important for us to engage leadership and each of our facilities that we support have a governance committee that really is dedicated to improving quality in their healthcare facility. And then one of the things that we've started with the 12th scope of work, and it will continue with the 13th scope of work, is a community health model. So currently, with the 12th scope of work, you can be a quality improvement organization in a specific state, but another contractor besides Alliant is supporting the hospitals in that state. So it's really disjointed now, and is resulting in some very fragmented models. I'm happy that CMS realized that that was not the best model to use when we're really trying to coordinate care, that the same quality improvement organization needs to be working with the community, with the nursing home, with the EMS, with the hospital, and all the other healthcare players in the community if we really want to have that coordinated care and really improve the health of the population that we serve. CMS also wants us to focus more on the use of data. We are providing data back to hospitals. It's from claims data, so that is not timely, as you all know. If you're working with us, it's about 4 months out. So really trying to improve the use of data and try to use more real-time data than what we're currently using. CMS certainly wants to lever all outcomes, program design, payment models, contract structure, selection of contractors, and the role of CMS and technology, and put all those together to improve outcomes. And as I indicated, here it is again, that CMS really wants us to be positioned as the national resource for quality improvement. And understand, since this is funded by CMS, any assistance that we provide to any facilities that we work with is of no cost to those facilities that participate with us. So let's take a minute and look at some of the national strategic goals for CMS. So we've got 4 pillars that CMS really wants us to focus on, and that is equity and engagement, outcomes and alignment, safety and resiliency, interoperability, and scientific advancement. So let's take a deeper dive at each one of these. So if we look at equity and engagement, CMS is really focused on making sure that we're advancing health equity and looking at whole person care. As far as engagement, we need to engage the whole community and the individuals to become partners in their care. We're seeing a lot of this transition as we're ending up the 12th scope of work. For safety and resilience, achieve 0 preventable harms. We certainly are working toward that goal now. All-cause harm is a very difficult goal to achieve 0 harm, but that's what we're working for. And some of you have done an excellent job in that area with 0 harm for most of our patient safety measures. So we will still continue to work hard in that area. Under resiliency, with COVID, it really bogged our health system down, and everyone became very tired. And we realized that we really got to take care of the people that take care of others. So really working on resiliency and providing some tools and resources in that area. For outcomes and alignment, we want to improve quality and health outcomes across the care delivery model, and certainly align and coordinate across programs and care settings. So when I mentioned that the same quality improvement organization would support all facilities in that specific state, is an example of how CMS is really trying to align and coordinate across programs. For interoperability, we certainly want to continue to support the transition to digital and data-driven healthcare. I think we've certainly seen that with COVID and the outcomes that we've had with telehealth, and CMS will continue to provide more resources to us and more availability through telehealth. And I think that's very, very important as we reach out to our rural communities to provide access to care in that manner. So currently, under the 12th scope of work, there's 12 quality improvement organizations. CMS is redesigning the current blueprint, if you will, for these quality improvement organizations. So each color represents the region that the quality improvement organizations will be able to bid on for this contract for the 13th scope of work. So we are in Region 3, and so you can see the states in green that will make up this Region 3. Certainly we will, Alliant Health Solutions will bid on this scope of work. We do anticipate to have some competition. So like I said, there's 12 quality improvement organizations across the country. So, not all 12 of those will be able to receive the contract award for these 7 regions. We do anticipate that there will be some subcontracting with other QIOs, but we are definitely going to be bidding on our Region 3, and hopefully we'll receive that award. Now, you may ask yourself, why is it that the darker green has so many more states and the brown only has 4 states? 5 states. So what CMS did was they looked at the number of facilities and the population across the states to try to make the support that each of the quality improvement organizations would provide equitable across all of the regions. So there should be a very similar number of facilities that each region will support across the country. So again, each of the states in our region will be supported by the same contractor, regardless of the type of facility and regardless of the community. What we're anticipating is that CMS is really wanting us to use data to drive down to see which communities have the most opportunity for improvement in a variety of measures. Is it diabetes? Is it hypertension? Is it patient harm? Is it adverse drug events? Is it opioids? Whatever that issue might be, CMS is expecting the quality improvement organizations to work within the community and with those providers and resources within that community to improve the quality of care for our patients in those communities. So there will be one task for each region. Like I said, unlike the current work where we're supporting hospitals in Washington State, and there's a different QIO that's working with communities and nursing homes in that area. The same way in Florida, which really is not coordinated care and coordinated efforts across the QIO. Once the award is made, the specific QIO that is responsible or that has been received that award will be the exclusive provider of all quality improvement in that region, regardless of the type of facility. With the hospital quality improvement work, that was open to any hospital quality improvement contractor could work with any state across the country. And that really created a lot of competition between the contractors. So CMS has aligned this in a manner that there's no competition amongst contractors, that every facility within that state would work with that same organization. So I know that was a lot of information in a short period of time, but I just wanted to give you a brief overview of what to expect in the 13th scope of work. I hope y'all are excited. And if you're not currently working with us or whoever that new award, whoever receives that new award for the 13th scope of work, that you will consider working with them. It's definitely free technical assistance. It's consulting for free that the federal government is funded. So with that, I will open it up to see if there's any questions.
Thanks, Donna. Any questions? You can either unmute yourself or feel free to use the chat function.
Well, again, thank you so much. I appreciate your time, and I hope everybody has a great rest of their day.
Thank you so much, Donna. We really appreciate it. Charles, would you like to introduce our next speaker?
Absolutely. Thank you. Next up, we're going to hear from Tanya Chitwood. She is the Chief Nursing Officer at Elbert Memorial Hospital, and I believe she'll probably be joined with Kelly Smith, who is their nurse in charge of quality. So with that, I will turn it over to Tanya to share with us about managing hospital-acquired infections and how they've worked to improve their patient outcomes. So, Tanya?
Good afternoon. This is Kelly. I am the quality director, and I will be the one presenting today. But I first want to thank everyone at Georgia Southern and the Office of Rural Health for giving us this opportunity to be able to do this presentation on our award, Reducing Healthcare Acquired Infections. So we're just going to do a little short presentation. And I think Angie's going to help me with my slides because we're having some technical difficulties. So if we can move to the next slide. Thank you. And again, like I said, we're going to be talking about how our little critical access hospital reduced our healthcare acquired infections. And our data will be from September of 2021 through July 2022. And we all know that as critical access hospitals, you know, we realize with our small numbers that just one patient, you know, contracting a healthcare acquired infection can be detrimental to our patient population. And healthcare acquired infections, you know, they affect hundreds of thousands of people annually. And the three top healthcare acquired infections, of course, are urinary tract infections, and that does include your catheter associated UTIs. And then we have our bloodstream infections and our surgical site infections. Next slide, please. And of course, we all know that in healthcare, the most important infection prevention tool for our healthcare acquired infections is proper hand washing and teaching universal standards. And we do that to all of not just our clinical staff, but to all of our employees. And, you know, this project was initiated to evaluate and improve our processes in an effort to reduce our HAIs. Next slide, please. Now, for our plan or our improvement, our goals, again, was to reduce our health-acquired infections. And by doing this, we tracked all of our patient infections. And we monitored each of those, and we set a goal for ourselves of 0. So we definitely did not want any. And how we involved our frontline staff here at EMH, it was, of course, it was clinical driven, but again, I'm going to talk a little further about how we involved everyone and involving that frontline staff. You know, the transition of implementing the risk reduction protocols. Like I said, they were nurse driven, those nurses that were caring for our patients and those that were proactively facilitating their care. And then our hand hygiene was closely monitored, and that was monitored by not just our infection preventionists, but also some of our nurse clinical supervisors. Unbeknownst to the clinical staff, you know, at times, like I said, they did not realize that they were being monitored as far as their hand hygiene. So it gave us a really good raw outlook to see, you know, what we were doing and things that we needed to improve upon. And also our pharmacy and therapeutic committee, they had some accountability and they worked closely with our infection control preventionists. Next slide, please. Of course, our target population, in order for us to do this, again, all of our employees with a focus on direct patient care. That included our registered nurses, our LPNs, our certified nursing assistants, our monitor techs. It also included all of our lab employees, our radiology department, and our environmental services. So it was pretty much everyone that worked here. And like I said, that, you know, came close to or had any kind of patient contact. Next slide, please. How we involved our hospital board and trustees and our senior leadership, medical staff, our nursing staff, and patient advocates. Each month, every department reports to our quality director, and then through the quality director, we report off to our medical staff, and we do that through our med exec committee meetings, and then again, we do our P&T meetings, our pharmacy and therapeutics. And as far as nursing leadership team, our nursing leadership team kept the project at the forefront by sharing those results with our clinical staff in shift huddles, and not just only our clinical staff, but again, our radiology people, our lab, and our EVS employees. And we do that in the mornings through our shift huddles and through our team meetings with our frontline staff. Next slide, please. How did we incorporate the patient role into the hospital culture? Well, our entire healthcare team is encouraged, excuse me, and expected to be an advocate for their patient. And we wanted to make sure that our staff ensured consistent communication between our patients and their families and our medical team. And, you know, by doing that, when we have our shift huddles in the morning, that allows our direct care team to be able to communicate with the patient and to be able to communicate with those family members and our medical staff. Our clinical staff delivery education, we do that in plain language so that our patients and their families can understand. And that way, you know, we had an increase in compliance when we did that. Next slide, please. Some of the, you know, overcoming the obstacles for those challenges or the buy-in, you know, during the implementation, we wanted to make sure that we gave a sound message and explanation of the benefits of this program, because we wanted to ensure that, you know, we wanted to implement changes and that was necessary for our program. Next slide, please. How do we share those results and how the changes, you know, what did we do to improve our quality and safety? Well, first, you know, we knew we had the need for improvement. That was what was initially identified by our nursing staff and our infection control program. In the education, we included the importance of proper perineal hygiene, hand hygiene, and the correct procedure for specimen collection. And also with our staff, they received training on catheter-associated UTIs and appropriate catheter use. And then after we obtained the support from our medical staff, our employees were educated on the new process through, you know, we have an employee newsletter, and that went out, again, our departmental huddles, and then our leadership meetings. And then the last thing that we did to help improve those changes, our infection control nurse, she rounded on staff throughout the project to make sure that we were compliant. And she was also able to provide further education as needed when needed. Next slide, please. Some of the specific measures that we use to identify, monitor, and track our improvement. We evaluated the collection process and the reporting of our urine cultures. And nursing supervisors, they ensured that our specimens were collected in a timely manner. We monitored and audited our specimen collections and occurrences of specimen growth. And as far as that, you know, we monitored and followed up on all of our cultures, and we tracked and reported monthly to our accountable committees and our frontline staff, being our pharmacy and therapeutic committee and our quality program. We track those on a monthly basis. Next slide, please. And some of those obstacles or challenges with that data, to make sure that, you know, we were following up and giving the correct antibiotic for the right bacteria. Pharmacy worked really closely with our infection preventionist in coordinating to make sure that we were providing the correct antibiotics for our patients. And then pharmacy also helped to confirm accuracy of that data that had been reported to our infection control nurse. Nurses, again, were educated on and understood their role, knowing that, you know, without their commitment or without their buy-in, we could not have made these improvements and they would not have been achieved. And this was a facility-wide project. Next slide, please. This slide here shows our data from September of 21 through July of 2022. And this was the data that was tracked by our infection control preventionist. And what she does and what she did and what they continue to do is they look at this data and it is reported on a quality dashboard, and we keep up with this and we track this data. Next slide, please. Some of those obstacles that we encountered, communication with the provider, we saw that needed improvement. And to ensure the communication, was relayed to the provider, our infection control nurse received all of our culture results, and then she was the one that was responsible for notifying the provider. We didn't want anything to slip through the cracks. The collection time frame was initially identified as a barrier also that needed improvement. A physician would order a urinalysis and it may sit there for 2 or 3 days, where we have not collected it. But with us knowing that the time frame, like I said, we added what we ended up doing. We added a urinalysis to our order set for our admissions. And the nurses were educated on the importance of early collection and how the patient would benefit, and not just the patient, but also the facility. And also, early identification reduces any delay in treatment. And some of the revisions as the data was collected, again, education to the clinical staff, reminding them of the importance of a timely specimen collection. And also another thing to reduce oversight, again, the admission order set, we added a urinalysis on every order set. Next slide, please. And then for our act and our revisions and our final results, some of the things that worked for us and some of the things that did not work. I think infection control was the initial point of contact for follow-up for our culture reports. That helped ensure that the data was obtained and that it was documented and that it was reported. And early in the project, we identified that some of the patients had not received a urinalysis order on admission, and therefore the admission order set was changed to include that urinalysis, and that eliminated our potential oversight. Next slide, please. Some of the ultimate changes in structure, the process and outcomes. The standard process for obtaining our urine culture based on patient's ability was added to our clinical orientation and ongoing education. And then again, our urinalysis was added to the admission order set. And then our follow-up for our specimens was completed by our infection control nurse and pharmacy when appropriate. Next slide, please. And then our results. Initially, we had some temporary improvement, but then we took a decline. And when we noticed the decline, we realized that when we looked at it, it was based on increased attention, education, and process changes on admission. And then after that decline, we achieved the process and some of the procedural changes we implemented. Again, the order of the urinalysis on admission, that education, going a little further and explaining to the nurses, why it's important for us to go ahead and get those things early on so it doesn't delay the care and treatment of our patients. And certainly, of course, to keep up and to maintain these improvements, we have ongoing monitoring and communication. And we do that today continuously. Next slide, please. And then spreading the project, how we are doing this in addition to some of our other quality indicators that we look at. We have begun a sepsis campaign here to include risk reduction for health-acquired infections through continual reassessment and flowchart alerts when someone is admitted to our facility. Our electronic health records, we use CPSI, and we have incorporated that into our nursing assessment. When the patient comes through the ER, it's tracked. Do they have a fever? Do they have an increased target heart rate, respiratory rate? If they don't come through the ER, if they come through as an inpatient through our medical center or another provider, like I said, we capture those questions on our clinical assessment. So we're trying to catch those off the start of admission. So we have begun work, and we do see some improvement. Next slide, please. And how did we share this information? We shared this project with our hospital board and key stakeholders through our quality meetings, which go through our medical executive committee, and then our board receives quarterly updates on the progress and the trends. Next slide, please. And what processes did we do and implement to sustain our gains? Again, we make sure all of our patients receive a urinalysis on admission. All multi-drug resistant organisms infections are tracked and reported at the Quality Council meetings and through our National Healthcare Safety Network, which our infection preventionist reports to. And then again, all of our data is compiled and reported on a monthly basis. Next slide, please. And here is a picture of our graph. You can see where when we started looking at our HAIs for this project, we had an increase in October, November, and December. And then we took, then we saw some improvement there. But then when we noticed that when we took another rise back in February, we noticed we were going to have to change and implement some other processes, going that extra mile to educate our staff, not just our nurses and nursing assistants, and but our lab techs and our radiology, anybody that came in contact with patient care. It was clinical education and the timeliness of making sure we gather those urinalysis specimens. Next slide, please. I think that's it. Does anybody have any questions? And I do want to say one thing, because we still continue to do this and look at this every day, and we still have our morning huddles and still involve all of our employees for decreasing our healthcare acquired infections. And for our first quarter, we did have one in January, and then February and March we had none. In our second quarter, April, May, and June, we had none. And then for our third quarter, we're not finished, but I will tell you, in July we had none. And I'm going to say this, but August we did have 5, and they were COVID. And so we have seen a creep up of COVID come back. And this was a patient that had come in from another facility. So again, that's where we are today. But I do appreciate everyone letting us have this opportunity to tell you, how we did get to reduce our healthcare acquired infections. And I think Tanya and I, we have our email address on there. If anyone, would like to see what we did, you can certainly send us an email and be glad to share anything with you. But thank you again for giving us this opportunity.
Yes, thank you so much, Kelly. I think we do have a question. Linda? Oh, you're muted.
Uh-oh.
Sorry. Yeah, just a quick question. I was interested in your whole process and appreciate the presentation that you did and the results that you had. I was curious what your next quality improvement project is now that you've been so successful at this one.
Well, I will tell you, we are looking at achieving ROS, return of spontaneous circulation after cardiac arrest. And we, in the last couple of years, we've had some poor outcomes, but through clinical education, through some RQI training, which is a program, it's a software program that we have for all of our clinical staff to be able to go in and to do their mock resuscitation drill on their own time. We have to do it every 3 months. All of our staff, including our LPNs, we did at first have some resistance from our clinical staff because, again, it's new information, and it can be scary when you are a nurse in a room full of people when you are trying to resuscitate someone and you may not know what to do. And so we want everybody that is involved with that patient to be able to know what to do and the importance of why we do it. And again, we revised our code sheets that we had when we do have a cardiac arrest. When we do have a cardiac arrest in-house, we meet in real time after that event is over and come together as a team and talk about some of the things that we could do for improvements, what we should have done better, what we did good. You always want to make sure that, you tell your nurses, and not just your nurses, but again, your lab and your radiology employees, what you're doing good. But again, through those mock drills that we have once a month, we have one for day shift, we have one for night shift. We have a really good emergency management coordinator who helps drive that process, and a good nurse leader that makes sure that everybody is involved. So through those mock codes, through those new code sheets that we have improved the critiquing of the cardiac arrest in real time after the event, the new RQI system, we have increased our inpatient ROS from 0 to 29% overall. And if you get one patient back, that's something to be proud of. So that's what that was one of our goals. And like I said, we are working on that. And I think also when you involve your staff, especially your nurses, they begin to feel more comfortable. They're more comfortable in asking questions, and you want to have a just culture where your employees are, like I said, comfortable in asking those questions that they may not have felt comfortable with earlier on. Because a lot of people, in a code, I'm like I said, I've been a nurse for almost 27 years. They tend to stand back in the corner and it's like, I'm gonna be the one, I'm gonna write. I don't want to do anything. But when you educate people and give them that opportunity, they're more inclined to help. And so again, like I said, that's another initiative. That's what we're working on this year, and we will continue to do that. Thank you for that question.
Thank you.
Any other questions? All right. Well, thank you so much, Kelly. Thank you for sharing.
Thank you, Miss Angie.
Yes, definitely. All right. We're going to move into sharing with you all some information about our initiative last year called the Lead Academy. Betty, do you want to talk for a bit on this?
Absolutely. Thank you, Angie, and thank you so much to our guest speakers, Ms. Kelly, Ms. Tanya. Thank you, Ms. Donna, as well. It's very valuable information that you shared, and we really appreciate you sharing that with us this afternoon. We're excited to talk about the Lead Academy because this was sort of one of the first hospital leadership development initiatives as part of the FLEX programming that was targeted at critical access hospitals in our state. We had some really, really good outcomes, and so we wanted to share that excitement with y'all and then sort of talk and sort of brainstorm about sort of possible ways to enhance these sort of educational and workforce development opportunities that we can offer through the FLEX programming. So the programming was a two-part. We had a 5-part webinar series and some culminating on-campus symposium. We're really, really excited. We had huge turnout, huge engagement from our participating hospitals. This ran from February through June of this year, actually. And we started off with a webinar on leadership, on just sort of the fundamentals of leadership. We also talked about we did a Clifton Strengths Assessment, and we had participating representatives from critical access hospitals take the assessment and identify their individual talents and how to leverage those talents into in leadership. We also talked about self-care and the importance of just focusing on some of those self-care and self-love activities such that we're able to mitigate burnout. We had over 140 participants take at least one webinar, which is phenomenal. We had participation from 19 out of the 30 critical access hospitals in the state. And we had over 70 participants completing all 5 webinar series, taking the evaluation as part of sort of a record of their completion as well. These are all really, really fantastic stats, and we want to take a moment to say thank you. Thank you for engaging, thank you for participating, and this will not have been a success without your involvement and your commitment to workforce development. Some of the webinar outcomes that we had were also equally wonderful. 96% of participants reported an increase in knowledge following taking the webinars. 98% reported an intention to apply the things that they had learned or heard of in the webinar in their daily work activities. The overall satisfaction on average for all 5 webinars was 4.7 out of 5. In terms of our symposium, we had a swell time here on the Statesboro campus on June 15th. We had 22 critical access staff members and leadership from 7 individual CAS. Thank you to Candler County Hospital, Clinch Memorial Hospital, F&M Health System, Jeff Davis Hospital, Optum Medical Center, but Screven and Tatnall actually, and Wills Memorial Hospital for driving all over to Statesboro and spending a whole day with us. We had 2 really captivating guest speakers. We had Miss Jackson, Dr. Jackson, who was just phenomenal. We talked about burnout, and we just talked about ways in which we can leverage our talents, our skill sets as leaders to make sure that we're leading in a way that ensures that we ourselves are not getting exhausted or just sort of losing steam in the process. We also had the opportunity to engage in a simulation game Friday night in the ER, where it's a sort of systems thinking orientation where we played in teams and we managed an ER for 24 hours. If you haven't played this game before, please talk to those who have. It is really fun, and you learn a lot about yourself, but you also learn a lot about your team, and teams come together to really learn a lot about each other and how to operate within really sort of trying and uncertain times. So that was really fun. On the slide here, you see some of our pictures from the event. It was really great. The outcomes there too were fantastic. All of the participants reported an increase in knowledge. All of the participants reported an intention to apply what they had learned during the symposium. The overall satisfaction score was 4.9 out of 5. So before we started the LEAD Academy, we actually wanted an objective assessment of improvements in leadership competencies. So before the very first webinar, we asked a set of 5 questions that are collectively assessing leadership competency or leadership skills. At the end of the 5th webinar, we repeated those questions. And so on the screen, what you see is the results from the pre-assessment and the post-assessment. And you can see that for every single skill set that we looked at, being able to communicate effectively with your team members and stakeholders, being able to inspire your team, being able to delegate, being able to create positive and inclusive work environments, and actively seeking opportunities for personal and professional growth. We do see an improvement in every single one of them. And as much as improving by 17% in terms of delegation. I think a lot of people took away from this series of the importance of identifying not only your strengths as leaders, but also identifying the strengths of the subordinates or the people that you lead, and figuring out the best ways to engage them towards your collective or your mutual goals as an organization. So overall, we are really excited about the results. wanted to take this opportunity to share these results with you, but we also wanted to take an opportunity to thank you so much for engaging and for making this program a success. As we go through the programming today, we'd love to hear more ideas and sort of your suggestions on what the next step should be and how we can take this and build it up into something that would be of benefit to all of you. So with that, thank you so much, and I will turn it over to Angie and Linda. Oh, unless there are any questions, I apologize. I should have asked that.
Sure. Just real quick, Betty, we do have, I think
yes.
two participants of the Lead Academy that are just going to share
Yeah.
a couple thoughts with us today. So Rhonda, would you like to share?
Hi, Angie, thank you. I hope you can hear me well.
Yes.
Great. Well, I am Rhonda Durden, CFO for Optum, Titanal, and Screven, and I appreciate the opportunity to speak with you today. I participated in the Lead Academy series and attended the capstone training. And I find it's always worthwhile to get refreshers on personality traits and how to build a stronger team. After nearly 25 years in healthcare, I know that building a team is important as knowing the technical skills of accounting. I also appreciate the fact that you had speakers like Draffin and Tucker who offer additional insight to cost reporting, and I appreciate the comparison templates that were provided through the program. And no matter how long you've been in healthcare, there's always something to learn from cost reporting time. So appreciate that. Also, I will say that Dr. PBJ was just an amazing speaker. She was amazing at showing the warning signs of burnout and methods to reduce this. So just really appreciate her time as well that day. And the ER game, I just love board games, being an 80s girl. And you know, I find that was just a really good method of showing how important communication and working as a team is. So I want to say thank you for the opportunity to participate in those trainings. And thank you, Angie, for inviting me to speak today, and to the team for offering all these valuable insights.
Thanks, Rhonda. We're glad that you enjoyed it and learned something. I'm not sure, Misty, are you on the call? I don't see your name, but you may be joining with someone else.
Sorry,
Okay.
Misty had a death in her family, so she's not able to attend today.
Okay, thank you so much, Barry. We're sorry to hear that. All right. Betty, you want to put the slides back on and we'll move forward?
That's good.
All right, Linda, you want to talk to us a little bit about this?
Yes. So at this point, we are now, I think, in the third year of offering PDSA assistance and coursework for employees of all of our critical access hospitals. At this point, I believe we've had 7 hospitals with employees that have participated, and we're well over 20. I think it's closer to 25 or 30 at this point who have done some iteration of our training. So at this point, we had created an kind of on-demand online course, fully online, to teach the PDSA methodology to employees in hospitals, and hopefully to support initiatives like what we saw Albert talk about. I was feeling very good about the applicability of what we're teaching to help our hospitals be able to take on those type of quality improvement initiatives. So all that to say, for this year, the online course is available. We will offer this to start at any time at this point, rather than doing a cohort model. All we need to know is a name and an email to get you signed up, or your employees signed up. And so hopefully you will continue to let your employees know about this opportunity. It's very engaging. It's not terribly long. You could complete it in a week pretty easily if you were consistent with it. And we have had great evaluations of this course. So not just overall saying the course is good, but telling us what they're doing with what they've learned, with the knowledge that they've learned. So I encourage you, if you have more employees that are interested in signing up for this, to just let us know.
Thanks, Linda. All right, we are going to continue with our workforce development webinars in this year 5 of the program. We have 2 that are on our minds right now, and I think you probably heard Rhonda mention earlier, we did have Dr. Patrice Jackson come and speak to the group in person. We've asked her this year if she could do something online, so she is going to host a webinar for us, so we can get her message out even more broadly, and she's going to take a little bit deeper dive into some of our discussions on burnout. So we're excited to have her back for year 5. We're also going to bring to you a webinar on human resources. So this is something that we had heard what there was a need for, and so we're going to have a human resources expert kind of talk to you about what you can do as employees to actually support your human resources department. So we'll have that for you sometime in the new year, and just check back, read your emails, read our newsletter. So we'll be announcing all of this there and the website, and we hope that everyone can join. So finally, just to be aware that we still are offering all of our initiatives. So we still have our technical assistance per request. So you can reach out, you can do this through the website, or you can reach out to any one of the team, myself or Betty, or like I said, anyone on the team directly if you need technical assistance. We will also be doing stakeholder engagement sessions. So those are employee engagement. So let us know if you want to be considered for that. Betty?
Yes. Yeah. I'm not sure if I'm not on mute. Good. So yes, like Angie said, a lot of the resources will be in our newsletter, but will also be on our website. So if you haven't visited the website in a while, please do check it out. It is www.georgiacahcop.com. You can also sign up for program initiatives there as well. If you're not already included in our newsletter, please let any of us know, myself, Angie, or anybody on the team, and we'll make sure that we add you to the listserv. That goes out weekly as well, and it has a lot of resources, not just about the program, but also just resources that are broadly applicable to rural hospitals. So please let us know. So at this moment, we do want to make sure that we're respectful of your time and give you any time that we can save back to you. But we wanted to take this moment to get some feedback on sort of the things that really have been working as part of this program, the things that you would like to see happen as part of this program as we enter into the final year of this particular grant cycle. Evaluation is really huge on our mind. So we'd love to hear from you on some of the elements that you think have been effective that you'd like to see continue, or if you'd suggesting alterations or modifications to some of what we're already doing, we would love to hear all of that feedback. So we'd like to sort of open up the time to see if we can get any of such discussion going on, please. And if you'd like to reach out to us personally, that's also fantastic. If you'd like to use the chat function as well, that's also works really well as well. All right. Well, like I said, we would really love to be respectful of your time and give you as much time back as possible. So on behalf of our team, on behalf of the State Office of Rural Hospitals, State Office of Rural Health, we would love to say thank you. Thank you so much for your engagement over the years. Thank you, especially throughout the pandemic. I think we really relied a lot on your own resiliency to keep us going as a program. We appreciate all your commitment to rural and population health, and we look forward to working with you as we begin year 5. So thank you so much for attending. If you have any questions, if you have any feedback for us, any comments, comments, please feel free to contact any of us on the team. Charles, Angie, would you like to say something before we all sign off?
I think I'm good. Thank you everyone for joining us. We appreciate it.
Thank you.